So here tonight, we have Alyssa, myself, we have Monica, and we have Lorraine. We're pelvic floor physical therapists at Rockville Hospital. Our disclaimer is the information provided in this educational lecture is for educational purposes only. We are not here to diagnose you or provide you with specific treatment options. If you suspect you might have endometriosis, we recommend you consult with your medical team to seek guidance and proper treatment, which we will educate you on today. We do not have any financial ties to any products that may be presented in this lecture. Our objectives tonight are to define endometriosis, identify signs and symptoms of endometriosis, understand the role of physical therapy in the treatment of endometriosis, identify the functions of the pelvic floor, understand the relation anatomy has on management and treatment, identify helpful resources in management of endometriosis, and finding the right endometriosis care. So the World Health Organization defines endometriosis as a disease characterized by the presence of tissue resembling endometrium, the lining of the uterus outside of the uterus. It causes a chronic inflammatory reaction that may result in the formation of scar tissue, adhesions, or fibrosis within the pelvis and other parts of the body, sometimes referred by general OBGYNs as retrograde menstruation, which this theory has been debunked with lots of different resources. The most up-to-date and correct definition of endometriosis is characterized at surgery by the presence of endometrium, like epithelium or stroma outside of the endometrium, and myometrium, the muscle, usually with associated inflammatory process. A spectrum disease with a variety, as you can see in the picture here, we have the large intestines, we have the uterus, we have fallopian tubes and ovaries, and you can see all the little spots on the image there have little like chocolate areas, and that can be defined as endometriosis with surgery. There are several types of lesions that have been described. So there's superficial peritoneal endometriosis, which can be found mainly on the pelvic peritoneum, so in with the anatomy, which we'll go over. Cystic ovarian endometriosis, aka an endometrioma or a chocolate cysts, the cysts that are found on the ovaries. Deep infiltrating endometriosis, also in the literature known as DIE, which is endometriosis found in the rectovaginal septum, bowel, or the bladder. And then in rare cases, endometriosis has been found outside of the pelvis. Endometriosis can cause severe pain, sometimes including the full body, and also infertility. The prevalence, it affects an estimated of 10% of women, and many go 8+ years without a diagnosis, which is why we're here today educating you. So we have 4 stages of endometriosis. Stage 1 is minimal. There are superficial or small lesions or implants outside of the uterus or near pelvic organs. Stage 2 is mild. It encompasses more and deeper implants in the pelvic area, as noted in the pictures. Stage 3 is moderate. This is a deep infiltrating endometriosis stage. Many deep implants are in the pelvic area and other body parts. There are small cysts on one or both of the ovaries, and some adhesions are present in the abdomen. Severe, a deep infiltrating endometriosis stage, and large cysts on one or both of the ovaries, and dense abdomen and pelvis adhesions. You can see as the stages progress, there are more adhesions that are on the pelvis. Signs and symptoms of endometriosis. I like this picture because I feel like this really represents what the general public thinks endometriosis is, which is just a painful period. But really, endometriosis is a variety of things. So the number one thing is that many people with endometriosis end up missing school or work due to painful periods. There's chronic pelvic pain. There can be pain before and or during their period, pain during or after penetrative sexual intercourse. Bleeding is associated during and or after sexual intercourse, painful bowel movements, painful urination or bladder pain syndrome, fatigue, depression or anxiety, abdominal bloating and nausea, and lower abdominal pain. So I like how the picture really shows that people are not feeling good at all when they have endometriosis, and it can really affect their everyday life. So the first line of treatment is hormonal-based therapies, which many of our regular providers will put you on. We have oral birth control, which is a combination of estrogen and progestin, which suppresses endometrial growth and ceases ovulation. Then we have some different medications that Dr. Alammari will talk about, but we have Lissa, which you've probably heard of or seen on the market, Lupron, and there's a new medication that Dr. Alammari will mention, Myfembry. So these medications stop the ovary from producing estrogen, putting the patient into a menopausal state, thus shrinking the endometrial lesions. Another type is a progestin, which works to keep the ovarian hormone levels low to prevent ovulation and suppresses endometrial growth. Some of the names that you may hear on the market are Provera or Depo-Provera. And then we have danazol, which exhibits some androgen, which is a male hormone effect and reduces ovarian hormonal production. This is just a Band-Aid and is not a cure for endometriosis. So excision surgery, laparoscopic excision is the best option to get rid of the endometriosis in your body. Many general OBGYNs are not skilled in excision, thus leaving some endometriosis behind, which causes more pain. Many individuals with extensive endometriosis will require more than one surgery, even when the surgical excision was performed by an expert. These pictures can be triggering for some, but they are great pictures to see what our excision specialists will see when they go in for a laparoscopic surgery. So the top picture is an endometrioma, which you can see a very dark chocolate colored area underneath the white, which is a chocolate cyst. And then you can see in the bottom picture, the top left, which is A, you'll see the it says adhesions on it, and so that's an area that the excision surgeon will go in and remove from the body, that it doesn't cause any issues, and really and look at entire abdomen so that they are move organs around and getting down to the base of the organs to make sure there's no hidden endometriosis. An endometriosis specialist is somebody who has extensive specialty training in endometriosis with conservative medical management or surgical excision. They have a fellowship in minimally invasive gynecological surgery, or you'll hear or see on some websites that they are in caseload of endometriosis. And there are some who will pursue another fellowship working directly with an endometriosis excision surgery. You want to make sure you're looking for a doctor who will take the time and listen to your story. We will be joined by Dr. Alammari from Mansfield OBGYN Associates at the end of the lecture to discuss a lot more in detail.
Hi, I'm Monica. I'm one of the other therapists. I'm going to be taking over for the section on anatomy. So first, we're going to go over anatomy of the abdomen. So the abdomen houses all of our major organs, which includes the diaphragm, liver, stomach, pancreas, kidneys, ureters, adrenal glands, small and large intestines, spleen, appendix, bladder, and uterus. Within the abdomen, we also have fascia. Fascia is a layer of thin connective tissue that wraps around and supports all the different structures within our body. The abdomen specifically contains peritoneal fascia, which lines the abdominal cavity. And then there's visceral peritoneum, which is another type of fascia. And that covers the outside of each organ that's in the abdomen. So the peritoneum supports organs and it serves as a passageway for nerves, blood vessels, and lymphatics. Injury to the peritoneum, like from illnesses such as endometriosis, can cause these adhesions or pathological attachments between the different structures. So you can think of fascia as when you get chicken breast from the tree where there's that thin coating on it, that's fascia. You can also think of fascia as plastic wrap. So like when you take plastic wrap and you take it out of the container and everything sticks together, that's kind of like endometriosis. So that plastic wrap sticks together, it falls up, and you just so now we're okay. Great. The pelvis is made up of 3 bones fused together. This bony cage helps to hold and protect the uterus, bladder, and rectum. The pelvis also serves as an attachment site for various muscles in our back and legs, as well as the pelvic floor. There are 3 different layers of pelvic floor muscles, which not only help to provide support to the organs above it, but also assist in bladder, bowel, and sexual functions. We're going to go more into depth into each of these layers in a little bit. So we also have ligaments. They not only attach onto the bony pelvis itself, but it also helps to hold organs such as the uterus in place. Lastly, just like in the abdomen, we also have fascia. That fascia is going to coat those organs, muscles, ligaments, nerves, and blood vessels that are housed in the pelvis. So with all these different structures, there's a lot packed into a small area. So this is a really great picture. You can see in this cross-section that there's a lot of stuff going on. And so we can start to get an appreciation of everything that's in there and everything that can be affected by endometriosis. So you can see in the front, we have the bladder, and then in the middle is the uterus, and then in the back is the rectum. Up above that, those yellow lines are nerves coming off the sacral plexus, like from our spinal cord. And then you can see there's a thin pink band of tissue in between that yellow stuff. The yellow stuff is fat, by the way. So that thin band of pink tissue, like those are our pelvic floor muscles supporting those organs. And so the space between the uterus and the bladder, that's referred to the retrovaginal space. And then the space between the uterus and the rectum is known as the retrouterine space. And so a good surgeon will look at everything, obviously, but these are very common areas for endometriosis to hide. And so when we think about those adhesions or issues, it makes a lot of sense how things can be pulled in the wrong direction and cause pain, constipation, difficulty with urination. If it attaches to those nerves, you can even get some nerve pain like numbness, tingling, and burning. So now we're going to go a little bit into the pelvic floor muscles themselves. So we have 3 different layers, and this here is layer 1. So this is also known as the urogenital triangle. So up top, we're looking at the ischiocavernosus around the vaginal opening. We have vulvospongiosis, and then connecting both of our sit bones, we have the superficial transverse perineal muscle. And then the last thing that's involved in this layer is the external anal sphincter, which goes around the rectal opening. In layer 2, we have what is called the urogenital diaphragm. So this is just one little layer deeper than layer 1. And this includes the deep transverse perineum, which again runs across the pelvis, connecting those two sit bones, and it's just below its sister muscle, the superficial transverse perineum. And then we also have the urethra. These muscles wrap around the urethra, and they primarily help with peeing. We also serve tissue that serves as an attachment point for the muscles and organs above it. Then layer 3, this is our deepest layer of pelvic floor muscles, and it's also known as the pelvic diaphragm. So within here, we have a big group of muscles called the levator ani. This includes the puborectalis. You have just the plain old coccygeus in here, as well as a couple hip muscles such as the piriformis and obturator internus, which are neighboring the pelvic floor. These can, if you have stuff going on here, you can also get a little bit of hip pain. So in this next picture, it's just another picture of the layer 3 muscles, and you can see how they attach onto the bony pelvis, and they make what kind of looks like a hammock, and that helps to support the organs above it. So now that we've seen all these muscles, we can talk a little bit about their functions. So the first thing is, well, they're the 5 S's. So the first one is sphincteric control. The pelvic floor controls when we pee, poop, or pass gas, so that we're able to go when we want to go, and we're able to hold it when it's not time. The second thing is that it provides support. So it supports our rectum, our bladder, our uterus, and those abdominal organs against gravity. The third thing is that it helps to stabilize and form our core. So it gives us stability to our back and our pelvis so that we can do what we need to every day. The fourth thing is that it provides sexual appreciation. So these muscles can assist in pleasure and orgasm, but when dysfunctional or tight, like they can give us pain. And then lastly, it serves as a sump pump, and it helps to circulate fluid and blood back towards the heart.
Hi, everybody. I'm Lorraine, and I'm going to discuss the role of physical therapy with the pelvic floor. So what do physical therapists do? Well, in the general terms, we work to promote and maintain and restore health through our physical examination, our assessment and diagnostic skills and management. We help make prognosis, we educate our patients, we do physical interventions, we work on disease prevention, health promotion. And we basically see it from head to toe. Pelvic floor is a specialty within the world of physical therapy, and that's where we focus on the pelvic floor, its relationship to our abdominal, hip, and low back musculature. We treat a variety of dysfunctions, bowel and bladder incontinence, constipation, urinary urgency, frequency, pelvic and abdominal pain, pain with sexual activity. We work with prolapse, pain during pregnancy and postpartum, as well as prepartum and postpartum, just exercise and education to help make the birthing process easier. And we deal with abdominal muscle separation. So what's our role in treating endometriosis? Well, we'll assess and address any physical limitations that might contribute to your pain. We're going to look at movement strategies to help, during flare-ups. We might suggest stretches, yoga, dynamic movements, a lot of education on the diagnosis and how it went on. And we do a lot with symptom management and pain reduction. So what's a PT pelvic eval entail? We're going to take a very thorough history. Like I said, I talk about, tell me your story. So your medical history, when did this all start? What's your pain? What are your symptoms? What's going on with your bladder? What's your bladder function? Same thing with your bowels. Are you having trouble moving your bowels? Is it painful? What's your past surgical or endometrial interventions? Some of the old ways of being treated were what they called ablation. So we want to know all about that and how you did with all that. We also do an orthopedic screening.
All right, so looking at the anatomy that Monica showed you, you saw how those muscles are going onto the pelvis and where they're attaching up to the tailbone. So your back could be involved. We want to look at your hip mobility. What's going on? Is that contributing, to some of the pain that you're having, or is endometriosis causing pain into those structures? We're going to check out your core and your leg strength. Again, it all works together. Think of that abdomen as like a big canister, and the pelvic floor is the base of it. We want to look at your breathing patterns, and we'll go more into detail for the treatment of how we use breathing as well to help with your pain. And we're going to assess that fascia. And then we're going to look at the pelvic floor itself. We like externally to look at and we observe, what's going on around, the vaginal opening, around the anal opening. What are those muscles doing? When we ask you, do you know what it means to engage those muscles? What's the coordination? Can you engage and then relax and gently bear down? And then we really want to do an internal examination. Very different from when you go to the OBGYNs. We're there to assess your pelvic floor. We're not there to evaluate, your uterus, your ovaries. We're just looking at those muscles, feeling the muscles. And that's how we find the muscles, is through, the vaginal opening. Pain, what does that mean? That could be triggers. You've got spasms going on in there. And we want to work on those. We want to assess the strength of those muscles. Once we get that whole picture, what can we do? Manual therapy is a big component. We address the scar tissue with that. What we describe as that endobelly, that pain, inflammation, things we can do to work on that. Pain with urination or bowel movements. Again, I've had patients that they've had endoscarring wrapped around their, rectum, and like, I can't move my bowels well, and able to, after the surgery, like, whoa, that now it's much easier to go. Looking at their back and their hip pain, the breathing techniques. This helps to, what we like to say, facilitate relaxation, or another term you might hear us use would be down training. It's very difficult to tell somebody in pain to relax, calm your system down. So we like to use a different word, all right, kind of de-amp that nervous system. We'll bring exercise into the program. We find that yoga incorporates the breathing and the stretching. Pilates may be an option. Strength and coordination exercises. Looking at that core is very important. And then we need to teach you how to manage this, right? There's ways for us to teach you how to do some gentle fascial releases. There's also ways that we teach you to even do some internal trigger point releases. We're going to talk about movement strategies, some behavior modifications. Is there certain things that set, some of the pain off other than the endometriosis itself? And then we may use modalities. So heat and ultrasound and electrical stim and TENS units or potentials. So manual therapy, what does that entail? So we do myofascial release. We do visceral mobilization. Your organs are supposed to move around nicely on each other, but they can get stuck. So we're able to address that. We do soft and deep tissue mobilization. We do fascial cupping. We do scar massage. We do joint mobilizations. There's a whole bunch of, things we have in our tool bags to address. Breathing techniques. So here's the goals for proper breathing is we want to get relaxation going. It helps with stress management. And again, I use the word down training, or I like to say also de-amplifying that pelvic floor, and it helps us coordinate with the pelvic floor muscles. And there's a variety of techniques that we do this. We do diaphragmatic. So when we do diaphragmatic breathing, so you're inhaling, nice and deep, and almost you want to feel like it's filling your belly. When this happens, the diaphragm is going to descend and the pelvic floor descends as well to allow that breath to be taken. On the exhale, it's just the opposite. The diaphragm ascends or rises and the pelvic floor goes with it. So that coordination can help quiet the system down, which can help with some of your pain. We talked about box breathing. So it's a way to do your breathing in like a sequence. So think of a square. So you're going to inhale, you take it 4 seconds, and then you're going to hold that, all right, for 4 seconds and relax for 4 seconds. We do visualization and guided imagery, pursed lip breathing, the 4-7-8. It's another way, again, to get that breathing. You'll go deep breath in through your nose, take 4 seconds to do the breath. Then you hold it for a count of 7, and then exhale slowly for an 8-second count. And we teach different ways to start off with 4 reps. Again, just to get your body into a way to help some of that tension ease up. There's another technique too to try to get the diaphragmatic breathing, alternating nostril. So you hold one side of your nose and you inhale, and then you move your finger over to the other side now, and then exhale through the one that you were holding first. And again, it's just a way to kind of get this system. A lot of times people are like, I don't think I can diaphragmatic breathe, but this is how we help teach you to do that. Exercise. Your program is geared specifically to you. So here in this class, we're not teaching different ones to do. So we look at low impact. We look at stretching, walking, yoga for flexibility, balance, relaxation, mindfulness. Yoga is a great tool for this. Pilates, working on our core and our coordination. So we got to get you to be able to do some things as well, because you can't come to therapy forever. So we teach movement strategies, behavioral modifications. If there's something that maybe triggers you having to go to the bathroom or triggers your pain, we work on that. We look at your fluid intake in your diet. There might be foods out there that you're eating and didn't even realize it that could be causing some of your pain. They can be, cause inflammation into your body. We talk about stress management. So what happens when we have pain, right? The body's going to want to protect itself. So we want to kind of cocoon around that, but then that ends up going into tightening even more. So then it becomes painful further, and you get into this awful pain cycle. So we want to do techniques to help you manage that and help get you opened up to be able to understand what's tense and what's a relaxed or released situation. And we talk a lot about nowadays mindfulness. We talk about wellness, but mindfulness really has a big place. We don't give ourselves time to take care of what our needs are. And so we want to help try to bring that to you. You deserve to take care of yourself. You deserve not to be in pain. Modalities. So these are, we call them our electrical or our equipment that we can use. So ultrasound. This is different than ultrasound that we have when we're pregnant or for diagnostic reasons. So ultrasound, just because you can't hear the sound waves, and we use it in the clinic, and it's more for warming up the muscles, relaxation, softening the tissue, so then we can use this as a preparation before we get in there and do some of our manual techniques. We might use electrical stimulation for pain relief, and if it seems to be helping, there's TENS units and eStim units out there that can be purchased, very, very inexpensive out in the market now. And you don't necessarily need a doctor's order for that, unless you want to try to get your insurance to pay for it. But we can talk about that, separately. Heat is wonderful to use in the clinic and at home. We understand that you're in pain, and this is, a scary situation coming in, and kind of talking, bearing your soul to us, but we're here to help. And these are some of the ways that we want to help you get relaxed and work with us. So overall, ultimately your goal is our goal. We want to decrease and manage the symptoms. Might have pressure in the pelvis or heaviness, if there's any urinary incontinence, if there's constipation, if there's pain with intercourse, any of the abdominal and back and pelvic pain, we want to help. And of course, the big thing, this can really affect, this endometriosis pain can really affect your function and your quality of life. And that is also very important. You shouldn't have to be missing work and school for this. You should be able to participate in your recreational activities, playing your sports, being able to go out there and socialize with family and friends. If you want to take a picture of this slide, all right, this is just some helpful resources out there for you all, okay? There's a great website, Nancy Snook. It's an endometriosis, like chat room blog, type of thing. Just there's so much information out there, and to be able to get onto support groups. And I think we're hoping that we can get Dr. Alammari in here next. Alyssa's going to introduce her.
Can you hear me?
Yes.
Yeah.
Yay.
I'm going to mute us so that you have the floor, okay?
Okay. Hi, everyone. I'm very thankful for Alyssa, Lorraine, and Monica for this wonderful presentation, and really for being excellent pelvic physical therapists, but even more importantly, big advocates for endometriosis patients. I get private messages all the time from Alyssa to follow up on patients and advocate for them. So thank you for all you do. I'm pleased to be here today to participate in this talk. I wanted to focus specifically on a very important issue, which is endometriosis patients getting the right care. So we all know about the delays in diagnosis that endometriosis patients suffer, but unfortunately, even after the diagnosis is made, there are significant delays in getting appropriate treatment, whether extended trials of ineffective medical treatments, or even having a surgery that's inadequate. So I'm gonna just kind of very briefly, in broad strokes, talk about the endometriosis care in general. It has different components. So medical treatments, usually the first line treatment is pretty much your birth control, right? So the birth control pills are very commonly used, Depo-Provera, the IUDs, progesterone only pills. Fortunately, for patients who didn't even get the diagnosis, usually the general OBGYN will place them on one of those treatments just because they do report painful periods. So the next class of medications, I called it a hypothalamic suppressive medications, but these are the medications that are gonna hit the gonadotropin releasing hormone. So we have Lupron, which I'd be very hard pressed to use. It's a very tough medication to use for patients, and it has a kind of an expiration date, so you can't use it for more than 6 months. And with add-back therapy, you can probably push it to a year. But our endometriosis patients are young, and apart from being able to tolerate this medication, it's not going to be a long-term fix. We have the other two oral medications. So Lupron is an injection. The other two medications on the market are Orilissa and more recently Myfembree. So Orilissa is an oral gonadotropin releasing antagonist. It's got the advantage of being a pill, so you don't have to go and get shots. It actually works fairly quickly. Lupron takes sometimes a few months to have full effect, but Orilissa works fairly quickly. But we'll have the same kind of end result of patients feeling essentially menopausal. And that's associated with a lot of bothersome physical symptoms, but also some issues with depressive symptoms and just feeling unwell in general. And again, although you can extend the treatment for a little bit longer than Lupron, it still has an expiration date. And the issue with all these medications essentially is bone loss. So you can't really have the patient on it for too long. The third medication is Myfembree. So Myfembree has a similar mechanism of action to Orilissa. They're two different medications from the same class. So it's a GnRH antagonist. But the claim to fame with Myfembree is that it has lower side effect profile because they incorporate into the same tablet a small dose of estrogen, a small dose of progesterone. So these doses are so low that it's not effective for birth control. So usually patients need to use an alternative method of birth control, and it cannot be hormonal, obviously. But it seems to be as effective as Orilissa, but again, patients run into problematic side effects even with those low doses of hormones. Aromatase inhibitors have not kind of hit the mainstream management of endometriosis, but these are things like letrozole. The idea here is that endometriosis is very sneaky. It has the ability of actually making its own estrogen by having aromatase activity. So these medications have been studied and used to treat endometriosis as well. I have used it sparingly in patients, but I haven't used it consistently. And again, has some of this low estrogen side effects as well. So surgery, I'm going to talk a little bit more about that in a few slides, but I kind of outlined some of the possible surgical interventions for endometriosis. Obviously, excision of implants or nodules, or deep infiltrating endometriosis. There's a lot of scar tissue involved, either from endometriosis or previous surgery that needs extensive dissection sometimes. I have operated for 5-6 hours in the past on endometriosis pathology. So these are not easy surgeries. Removal of ovarian cysts, obviously, these are your endometriomas. I'm not going to go into extensive detail about that, but endometriomas don't respond very well to medical treatment, and usually excision of the cyst is recommended. I didn't put in hysterectomy here. I'll address that in a few slides, so stay tuned. Adjunct therapies, we just talked extensively about pelvic physical therapy. It's an invaluable adjunct to treatment for endometriosis. You can start pelvic physical therapy before surgery, after surgery, and you can do repeat courses sometimes. And my patients really experience good results with that, especially with dyspareunia symptoms. Acupuncture has shown to have good results in some patients with endometriosis. Chronic pain, I always tell my patients with endometriosis that at the end of the road, there might be some residual pain despite all the surgeries and the medications that we may have to tackle in isolation. Narcotics are never a good option for chronic pain. So unfortunately, there's a huge lack in pelvic chronic pain clinics around the area. We had a good clinic when I trained at Bay State that addressed chronic pelvic pain, but they use several modalities that are non-narcotic to help our patients who did have persistent symptoms despite all the treatments. Our friends in gastroenterology and urology are very helpful to kind of aid in multidisciplinary approach. Often patients have not just secondary GI symptoms and urologic symptoms because of endometriosis, but patients with endometriosis have higher risk for having other pain-producing conditions like IBS and ICs. So it's always helpful to have a multidisciplinary team and ease of referral between a certain network that you work with, so patients are not getting the runaround and having repeat interventions or repeat diagnostics that have been done already. Behavioral health. So I think that's an important component that often is overlooked. Our patients are in severe distress, and they are often feel left alone to fend for themselves. I always say my endometriosis patients are very savvy, and it's because they had to educate themselves and advocate for themselves because there's a lot of lack of support. But it's very important to kind of support the patient as a whole. And I think having a therapist that worked with the patient to kind of work through the anxiety of the diagnosis and the fear of the next period and the pain and the neglect, and the list goes on. Next slide. So I put this slide because I really needed to emphasize that medical treatment is extremely valuable for endometriosis patients. Often in social media, I see that there's a push against medical treatment, and I think it's important to state that not all medical treatment is the same. Yes, there are medications that are very difficult to tolerate, like Lupron, and should never be used as a first or second line option, and definitely medications like Orilissa, Myfembree, and Lupron should never be used unless a surgery has been performed and there was resistance symptoms that did not respond to all the initial therapies. So, but medical treatment is very effective, and some patients actually never end up in the OR. I have patients with endometriotic symptoms. We put the patient on a birth control pill, and her pain completely resolves, and this patient never needed to have a surgery. Surgery is not without complications, and although it should never be delayed, it also is never the first line treatment. So just kind of wanted to mention that. And after surgery, there are a lot of good studies that show that suppressive treatment with hormonal contraceptives, whether the IUD, which is really great, even for adenomyosis, progestins, birth control pills, will lower the risk of recurrence and will keep the patient out of the OR for a longer period of time. All that being said, not every patient will be able to receive medical therapies. So if a patient has a contraindication, cannot be on hormones, some thrombophilias or increased risk of blood clots, cannot receive estrogen, cannot be on birth control, and cannot be on hormones. So these patients will have to be managed primarily by surgery. Patients who want pregnancy, so is just not feasible to put someone on a hormonal method. And I've actually had patients in my office who had to delay getting pregnant because they were told that they have to be on the hormones, and that's absolutely inappropriate. So those patients will benefit from surgery. Stage 3 and 4 endometriosis excision does correlate with increased spontaneous pregnancy rates after excision. Now, stage 1 and stage 2 after excision is still the jury out if that actually does help fertility. And then the last bullet there, I respect my patients. If the patient tells me, I just simply don't want it, there's no contraindication, she doesn't want to be pregnant, she just does not want hormones, she gets to make that decision. So for those patients, we will use surgery primarily. Next slide. So for surgery, often patients with endometriosis will need surgery. So if the initial medical treatment is ineffective, and I should emphasize that the medical treatment should not go on for years and years before a surgery is performed. I usually trial 1 or 2 medical treatments max for 3 months each before proceeding with surgery. And given the delay in diagnosis, I'm acutely aware that we should not be delaying surgery if the initial treatment is not effective. And again, if patient desires pregnancy, she will need surgery. There are lesions that do not respond very well to medical treatment. So I usually will book a surgery for a patient who does have an endometrioma or a deep nodule, because these do not respond very well to medical treatment. So endometriosis surgery, as you saw from the pictures earlier, is very complex and requires special training in advanced pelvic surgery. And I'll speak a little bit about that kind of training. But there's a lot of literature about improved outcomes, not just improved pain outcomes after surgery, but also surgical complications. It is essentially unethical for providers who are not high volume surgeons and operate on endometriosis regularly to take a patient to the operating room for an endometriosis surgery, because they're putting that patient at increased risk for injury and inadequate surgery, and probably needing a surgical intervention in a very short period of time. Lastly, laparotomy is almost never needed. So that's an open incision that's not laparoscopic, not small incisions. In fact, endometriosis surgery, in my opinion, is actually better performed by laparoscopy because it involves microscopic, not magnified examination of the peritoneal surfaces. A lot of the implants are very small and very subtle. And not all the endometriosis will follow the typical appearance that the general gynecologist trains to look for. So the laparoscope offers really good option to examine every tiny little kind of nook and cranny in the pelvis and identify subtle implants that should be removed. So I wanted to talk about oophorectomy. I see a lot of patients with endometriosis that undergo oophorectomy either because they had a big endometriosis cyst there or just to lower the risk of recurrence. So almost every endometrioma will be able to be removed without removing the entire ovary. And you just have to take your time and do meticulous kind of dissection of the cyst and preserve as much ovarian tissue as you can. So whether the ovary had an endometrioma or the surgeon decided to remove the ovary to lower the risk of recurrence, yes, there are studies that showed lower recurrence risk for endometriosis after oophorectomy, removal of both ovaries. But I think that the risk of removing an ovary, especially in a young patients, and most of our endometriosis patients are young, removing an ovary at a young age is very detrimental to the patient's health. And the risk will always outweigh the benefit of removing both ovaries in someone who's young. The patient's lifespan essentially will be shortened. There's an increased risk of mortality of all causes due to the loss of estrogen at this young age. So I'm very acutely aware of that, and I would be very, very hard pressed to remove someone's ovaries just for endometriosis. There are ways to lower the risk of recurrence, suppress endometriosis postoperatively with hormones and other medications. And hey, if we needed another surgery, we can do that. But removing both ovaries is really harmful for patients. Next slide. So a hysterectomy, often also patients have hysterectomies for endometriosis, and a lot of times those patients are young and kind of were counseled that this is the best way to make sure that endometriosis doesn't come back. So I just want to make the point that by definition, endometriosis is disease outside the uterus. The implants are outside the uterus. So removing the uterus is an inappropriate treatment for endometriosis alone. But there is a condition called adenomyosis, and we haven't talked about that yet in this lecture, but this is kind of, I call it the cousin of endometriosis. This is the same kind of tissue, but it grows in the wall of the uterus, right? It shouldn't be there. The wall of the uterus is a muscle, and it shouldn't have this type of tissue. And it causes very similar symptoms to endometriosis, and also very frustratingly difficult to diagnose by imaging. So there are kind of some symptoms and exam findings and imaging findings that make us think adenomyosis. In those patients, yes, a hysterectomy is definitely indicated. Adenomyosis is very frustrating because it cannot be excised apart from removing the uterus. But we also have medical treatments that can be effective for adenomyosis. When I operate on younger patients who are interested in preserving fertility and we're suspecting adenomyosis, I will always offer insertion of an IUD. Intraoperatively, we excise the endometriosis, put in the IUD to address any adenomyosis. Sometimes we do staged procedures. So we excise endometriosis, and if we have residual symptoms, there's good reason to suspect that the uterus is involved. And obviously fibroids are another condition that can cause pelvic pain. And in that case, a hysterectomy could be also performed. Patients with endometriosis, about 40% of the time will have adenomyosis. So it is a real issue that we will have to tackle at some point in the treatment. But a hysterectomy should never be done as a first line for patients with endometriosis in the absence of suspicion for adenomyosis. Next slide. So going back to the main point we want to drive home here is who should treat your endometriosis. So almost any OBGYN, hopefully with a good kind of knowledge of endometriosis, will have low threshold to start medical treatment. And that's appropriate, right? So patients will get the birth control pills, hopefully for not too long before, they're referred to a specialist if the treatment is ineffective. But yes, your OBGYN can definitely start the treatment. Now, if you find yourself on your third or fourth medical treatment, or you're kind of staying on the same treatment that is not effective, maybe it's time to kind of get a second opinion. Next slide. So what is an endometriosis specialist? This is a surgeon who completed a minimally invasive gynecologic surgery fellowship. So that's the frustrating part, is officially they're not called endometriosis specialists, right? The extra training that involves the endometriosis training is this MIGS fellowship. This is a 2-year fellowship that focuses on advanced pelvic surgery for a variety of gynecologic conditions. So when it started, it wasn't focused on treatment of endometriosis, but because endometriosis requires advanced surgery, this fellowship kind of naturally involves extensive training in the surgical and medical treatment of endometriosis and a lot of exposure. There are specialists that go on to kind of get even more training specifically in endometriosis surgery, but pretty much any MIGS trained fellow will be very capable of treating advanced cases of surgical endometriosis. Next slide. So when should you look for a specialist? One, if the medical treatment has not worked, and I put it back here, is that a 3-month trial is adequate. There's no need for further delay in surgical treatment. Almost any contraceptive option, a 3-month trial is completely adequate to see if it worked, whether it's the IUD or Depo-Provera or the progesterone pill or the combined birth control pills. So I have patients who come to me with 5 years of medical interventions. That's definitely not necessary before you decide that this is not working. I would say if you have been offered Lupron or Alyssa or Myfembree before surgery, definitely that's a time to say, no, I'm going to get a second opinion. I would never start these medications before doing surgical intervention. You really need to confirm that you're dealing with endometriosis, and then make sure that surgery itself wasn't gonna treat the disease before you go into these medications. So these are not low risk medications and should really be used sparingly. Should never be used as a second line, okay? If you're having fertility issues, you're having pain with your periods, you're going to the fertility doctors, you're having difficulty getting pregnant, it's very important to kind of get a consult for possible endometriosis as a contributor. As I said, patients with stage 3 and 4 endometriosis tend to be able to get pregnant on their own in many cases once the disease is excised. But obviously you need to have a good surgery to have that outcome. And then if surgery is considered, so you're seeing your general OBGYN, they're treating your endometriosis, they're calling it endometriosis, and now they're telling you, okay, let's go in and take a look surgically. So at that point, you need to start to ask questions of your surgeon, and if they don't seem to have specific expertise in treating endometriosis, that's a time to get a consult with a specialist. So some questions that you can ask, whether you're a general OBGYN who is offering you surgery or a surgeon that you refer to treat your endometriosis surgically. Do you routinely do endometriosis surgery? What's your volume? So we talked about high volume surgeons and better outcomes. Do you have special training in endometriosis surgery? So we have some surgeons who didn't go through this fellowship, but have extreme interest in the disease and kind of took it upon themselves to get mentored in the treatment of endometriosis, and that's valid. But they have to have had special training in those complex surgeries. The next one is addressing the excision versus ablation. So a lot of patients are starting to kind of understand this issue. Excision seems to be better for endometriosis. You want to remove the implant. The implant has roots. It's like my mentor used to tell me, it's like the carrot top, right? So burning the implant will leave some roots that leads to higher recurrence. In addition, implants on vital organs like the bladder or the bowel can simply not be burned. You cannot burn the bowel or the bladder. So those implants can only be removed by excision. So you need to ask your surgeons straight up, do you excise or do you burn, right? And if they tell you that we just burn endometriosis, they might not be the right person to do your surgery. And that addresses the next point. So are you able to remove disease on the bowel or bladder? I've had patients where I read previous operative reports and the surgeon decided to leave implants because they are on the bladder. Those implants, if superficial, can be easily removed without even the presence of a urologist, or in the case of the bowel, a surgeon, a general surgeon. And finally, are you able to complete a surgery for stage 3 or 4 endometriosis? These are very complex surgeries, and often patients will go to surgery. The surgeon will go in, look, sees stage 4 endometriosis, closes the patient up and treats her with medical therapy subsequently. And that's extremely inappropriate, right? So you need to know that your surgeon, if faced with this complex stages of endometriosis, will be able to tackle it right then and there. Next slide. So when you see an endometriosis specialist for a consult, it's very important to be specific about your symptoms. Where exactly is your pain? How does it feel? Is it sharp? Is it dull? Is it constant? When does it happen? Outside of your period, during your period, all the time? You really want to describe any bladder or bowel symptoms that you have. So take the time to kind of make a diary of your symptoms, when they happen, the frequency, what makes it better, what makes it worse, what have you tried for it before. Every consult I do, I tell the patient it's very important to tell me your story all the way from the beginning, from the first period, what you've tried, how did the pain evolve over time, because every patient presents at a different kind of stage of their disease. And just for us to have the most efficient plan of care, we need to know what has worked, what have been tried before. And bring records. It's very helpful. So we don't repeat imaging that was recently done, any MRIs, any previous operative reports, any images from the surgeries. It's extremely helpful just to have those there for your consultant ahead of time to review. So when you have your first consult, all this information has been reviewed by your surgeon, so there are not further delays to get records and so on.